the gynecologist's touch, the woman's touch, is something that we as women, or as men, if men are gynecologists, need to offer our subjects with a lot of love and compassion and consideration. If our touch does not communicate openness, then we are failing as doctors. And the funny thing is, I have 30 years of experience, only 15 minutes. The disparity doesn't go. So many studies in India, and we still don't know how common female sexual dysfunction is. Some studies say 14%, some studies say 73%, different contexts, different clinics. There's no dedicated study on female sexual dysfunction in our whole population. And unfortunately, it's not just India, it's a global issue. When we start talking about the scenario in India, we want to talk about the limited Indian research that's happening, the various kind of medical specialists that deal with women's sexual problems, and the challenges we're facing, and maybe a few solutions. You're all aware of the story of Draupadi, Panchali. 5,000 years ago, I want to picture yourself in that situation, sitting in that courtroom where dice is being played. The king loses to a manipulative game of dice. Money, land, and power. And the woman with 5 husbands, is dragged into that courtroom. She's on a period, barely wearing any clothes, because she was bathing when she was caught by a hair and dragged into this courtroom. Just imagine the humiliation. And the father figures sitting in that courtroom, nothing. They did nothing to stop her humiliation. Her pleas went unheard of. And we have a mythical balance, of the god, the male god who comes and re-robes her. 5,000 years on, not much has changed. A systematic review and a study in India shows that still relationship issues, financial issues, gender disparity, domestic violence, these are common contributors to female sexual dysfunction. So have we really evolved as a civilization? Have we evolved as human beings at all? Look at the modern situation today. I want to ask the women in the room, how often do you access a femtech, either on your phone or your laptop, to evaluate your health and to determine your sexual well-being? How many of you have a subscription to OMG Yes? Nobody. Femtech is falling behind for women's sexual needs. The most commonly used apps are period trackers and fertility trackers. Nobody talks about female sexual dysfunction. Education. How many states in India still have a problem recognizing that sexuality education and sex education is necessary? You cannot uplift women's health without educating them. And it's not just about giving them access to sanitary towels and toilets. It's more than that. Who holds the purse strings? What percentage of women today are financially independent? They're not dependent on a man in their family to give them access to education, to give them access to healthcare, to give them access to a local doctor who can actually speak to them. Not many women have that privilege. So if you're here attending this conference, you can understand what I say. You're in 0.01% of the population of India today. In India, women's role and most people get married, most people expected to have children, so women's roles are related to childbearing. Once the childbearing is over, sex is out of the window. How many of us come from families, even as middle-class families, where we went on holidays together? Everybody goes together. Daddy and mommy don't go alone anywhere. How many of our parents have given up their bedrooms so we can study? Because houses are small, cities are overcrowded. How many times have we known that a child is put to sleep with their grandparents? So many families. So many families give up the idea of sexuality in the name of accommodation. Kids often sleep with their parents. They don't even leave the marital bedroom. Urban slums, domestic violence, lack of privacy. I have a patient who grew up in a slum. He was exposed to sexuality from the age of 8. He was raped, I call it rape, by a girl who was 18 years old, who herself had been prostituted because of the lack of privacy, the exploitation, because her father was non-existent. She didn't even know who her father was. And then you also have in your clinical practice 35-year-old men who haven't got a clue what to do. Once you read couple sensate focus, she's got an erection, you've got penile containment. He says, what are you supposed to do next? And the woman is frustrated. That is the state we have today. So where do women go? And I understand that women go to many different kinds of doctors. But truth be told, the female doctor, and we call her a gynecologist because it's expected that all female doctors are part gynecologists. That's not the truth. When I worked in the UK, I was the only female Asian consultant in a teaching hospital of over 25 consultants. But in India, we're a bit lucky. At least we have more female gynecologists. Most women, in some part, they do gynecology work. So a woman is approaching another woman. Are women doctors in our country well equipped to deal with the problems that women come to them with? How open are we as women to another woman who's actually talking about her problems? This was a really important study, and probably the only one of its kind, and it needs to be repeated. 520 women were sent questionnaires to talk about different aspects of their sexual health and sexual well-being. 82% had a problem with sex. 74% of them suffered. 78% actually realized that having a decent sex life is important, but they can't talk about it. 64% of them said they could not talk to their partner about a sexual problem. Their main issues were relating to loss of desire, lack of arousal, lack of lubrication, dryness, pain, and discomfort. Less than 18% are satisfied. Can you imagine the quality of life these women have? Depression, anxiety, psychosomatic disorders, somatization. And they're going to end up with doctors that they will not get treatment from. I mean, global statistics say in areas of things like incontinence and sexual medicine, when women even turn up to their doctors, 75% of them leave without treatment or with incorrect treatment. It doesn't fare much better in other areas. There are methodological challenges. In India, a large part of the female population remains out of access to any kind of research that's done. There are language barriers, translation barriers, many tools that we use to assess sexual dysfunction, they don't even understand. And who conducts this research? If you and me have ever worked in any kind of segment like ICMR, you know research is conducted by medical social workers or general social workers. Very rarely does a doctor go out on foot to inquire what's happening with a woman's health. So how is it possible that they'll ever collect the information that's necessary? How are we ever going to change the scenario where we're delivering the right care to the right people at the right time? It is a really, really uphill task. When a study was done with psychiatry trainees, even they admitted, over 80% of them, that they would find hesitation in talking and taking a sexual history even if they were trained to do so. Because the socio-cultural barriers, the stuff that we grow up with, doesn't allow us to quickly open our mouth and talk about sex. My mother's a gynecologist. I'm trained in sexual medicine. I've been a gynecologist. As a gynecologist, you know what happens to have a baby. But do I get to talk to my mother about sex? No. And yet, she was the one who started to do a PhD in human sexuality. This is the depth of social conditioning we have, that talking about sex and sexuality, even in a permissive environment, is so difficult. So what happens in an environment where it is not permitted? In All India Institute of Medical Sciences, they studied 1,000 consecutive patients about their sexual problems. In these 1,000 patients, only in 36 instances did a woman accompany the patient. What about gynecologists themselves? Are they really that open to asking questions? In a study in North India, 137 gynecologists, out of a huge number, actually responded to a questionnaire about their understanding about sexual issues. Average duration of practice was 8 years. About 80% never took a sexual history. The ones that did were actually those practicing in infertility, which again ties to the factor that unless you're a woman who is interested in childbearing, nobody cares about your sex life. 85%, they don't know how to manage it, so they don't ask. This inhibition is a disservice to our population. The truth is, gynecology is not just about conceiving. How you do a hysterectomy, nerve-sparing surgery, incontinence, fibroids, anemia, tiredness, exhaustion, adenomyosis, pain, chronic pain, vulvodynia, warts, cervical cancer, prolapse with perineopathy. Our gynecological trainees and doctors need to be taught the importance of good surgical technique, nerve sparing, consideration for maintaining vaginal length, sensitivity to early menopause, post-cancer, post-radiotherapy and chemotherapy, so that they give the woman who comes to them a holistic treatment, including her sexuality and sexual well-being. The patients also need to be taught to request correct care. Unfortunately, when I get patients in my clinic and they narrate some of the stuff that goes on, my hair stands on end. A recent patient. She went to her gynecologist because she was having trouble having sex, vaginismus. The gynecologist told her, it's all in your head. It's because you haven't had a baby yet. Once you have a baby, everything will be fine. She says, well, that's my problem. I want to have a baby. So the gynecologist decided to do a transvaginal examination on her. She was refusing, but she forced the probe into her vagina. When the woman screamed, she says, yeah, you've got a little bit of a tightness there. Your hymen hasn't been ruptured by your husband. Did she actually ask the husband what he had? No. What she did then is unforgivable. Without anesthetic, without consent, she took a blade and she cut this woman. The sheer agony and horror of this woman, who could not have sex for a long time after that, until she actually showed up to a clinic where she was able to get help and talk about this incident. The husband was also incredulous. I've had so many partners before. Nobody has this problem. It doesn't exist. When you ask him, he's also developed erectile dysfunction and premature ejaculation. His problem was never considered. Nobody asked him. How many times do you get a clinic where the whole family shows up and says, fix this woman, she's got to be able to have sex with my boy. If she doesn't get fixed, we're going to dissolve the marriage, get her divorced. He'll find another one. We see these scenarios again and again. the gynecologist's touch, the woman's touch, is something that we as women or as men, if men are gynecologists, need to offer our subjects with a lot of love and compassion and consideration. If our touch does not communicate openness, then we are failing as doctors. Did you know that because of the sheer shame, secrecy, and stigma, sex education has renamed as family life education in India? It conveniently puts masturbation, both for men and women, sexuality, the role of sex toys, the role of pornography, the role of the internet, under the carpet. Joint families, nuclear families, everything I talked about, the economy, older women, they just can't open up about their problems. So many challenging beliefs about Down syndrome, about LGBTQ issues, about what women deserve. India has now more than 1,182 million internet users. 80% of both men and women access pornography on their phones. The world has shrunk. Women and men both travel a lot. Having affairs is considered quite normal. Sometimes, I have seen women who are very happy that their husbands access porn. They don't want to be bothered. They don't understand the importance of sex in their life. Men are relegated to second-class citizens once children come along the way. Women forget how to look after themselves. They don't maintain their health. Poor oral hygiene, cardiac disease, hypertension, prolapse, incontinence are really off-putting. We don't have services that help women to regain their sexual selves. We don't have a service that helps a woman understand that the primary relationship of importance for her has got to be her partner. The children cannot replace the partner. When men feel like second-class citizens in their own homes, sexuality and sex disappear. Female sexual dysfunction has a hidden cost. Would you agree that poor physical health actually leads to poor sexual health? Both for women. I mean, in men, it's very obvious. Erectile dysfunction is directly correlated with endothelial function, is directly correlated with poor metabolic health. But what about women? In women as well, poor metabolic health results in poor vascular health, results in poor sexual health. If a woman does not get aroused or become orgasmic, even with masturbation, she gives up. The man doesn't give up. The woman gives up. And she blames herself and her circumstances for saying, oh, who cares? I don't want to be sexual anymore. Unfortunately, such women also somatize more. They're accessing healthcare more. The cost of looking after them in any country, even if she's paying for herself, is higher because A, she's also getting neglected. She doesn't have money to access healthcare when she needs it. Until she actually falls sick, nobody's going to pay for her healthcare. Women in corporate India, they're the pioneers in the world. If I told you, in India has the highest number of women CEOs and leaders in amazing companies, amazing startups. 60% of them hit menopause, and 10% of these women will resign their posts because of menopause-related symptoms and fears of loss of libido, fears of losing their partners, divorce, etc. Such a loss to our country. Their quality of life is much poorer because it never gets addressed. How do we handle these challenges? I mean, organizations like ours, like CEPI, World Association, we do a lot. We do a lot. But these are big barriers. There's no formal medical sex education happening. There are lots of quacks. There's no qualification in sexual medicine that Medical Council of India or new NMC will recognize. There is a taboo around visiting psychiatry or counseling services. And did you know that overall, FOGSI has 30,000 gynecologists registered with them. Another 25, 30,000 odd are not registered with FOGSI, and about 5,000 to 6,000 are postgraduate trainees. For a population of over 1 billion, that is less than one gynecologist for 10,000. They cannot handle sexual issues of women. What are the solutions? Both doctors and the government need to work towards increasing awareness, reducing the stigma, and improving access to healthcare. As doctors, our job is to be 100% involved with healthcare access, to be able to make technology, our research available, to be able to share it with each other, to exchange our learning, to help the government form laws and policies that allow sex education to be implemented in its pure form in states across India. Certain guideline development is something that we can participate, we can educate each other, and we can help our clients access that through social media, through leaflets. We need to be more powerful in our voice than the quacks. How many of you are on Instagram? How many of you appear at least once a week to educate your patients? Don't you think, thank you, don't you think it is your behoven responsibility to drown the voice of quacks on Instagram? People who have absolutely no experience, no qualification to talk about what they're talking about. It is your social responsibility to do that, to do the real stuff. So it is a huge unmet need in India. And we as doctors, we have a commitment and a responsibility to share our knowledge, our expertise in a way that is easily understandable, that actually changes their life. I cannot imagine, I cannot even tell you. I've only been started talking for less than 4 months, but the kind of questions I get are so basic, simple, basic questions. People don't need complicated things. Simple, basic questions, answers will help them improve their sex life no end. Will help them get access. It is not a competition. Remember how few gynecologists there are? Even if the gynecologist next to you is educated about sexual medicine, there is no competition. You have a huge population to serve. Please don't be afraid of sharing your knowledge with other doctors. Nobody's going to come and compete with you and take your patient load away. It's not about becoming famous. It's about helping another person live long enough so that they have a great quality of life. I want to end my talk with this picture, and it's got a hidden message in it. We all think, dance and music is amazing, it's sexual, it helps you mobilize, and I tell all of my clients to learn how to dance. But the truth is, in India, particularly throughout South India, there's a custom called Devdasis. Young girls as young as 8 years, boys as young as 9 and 10 years are surrendered to temples in the name of poverty, in the name of serving God. They're gathered into prostitution, into exploitation. They have no names. They're not allowed to have a name. And all of this is still ongoing. The first efforts began way in the British era in the 1910s and 1920s to try and abolish this system. Till 2016, the government is still creating PDF documents that social workers can use to try and abolish this practice. There is a huge unmet need for female sexual dysfunction in India. Thank you.
Thank you, Dr. Neelima. I request Dr. Balamurugan sir to felicitate Dr. Neelima ma'am.
Thank you, sir.